from the Fauci Foundation Hospital. These are my disclosures. And this is what I will describe today. We'll briefly go through the descriptive data of our cohort because since it's a little baby still, we started this about 1 year ago, and so long-term outcomes cannot be mapped out yet. So we have talked since morning about the randomized controlled trials and their importance and approval and improvement of the patient care. They have remarkably improved the patient care in lupus in recent decades in terms of approval of different medications and testing of the newer interventions. But although they are very important in treatment scenario, but they are limited by their design that they have the strict inclusion and exclusion criteria. And recent literature, systematic meta-analysis, has concluded that about 40 to 60% of the lupus patients cannot qualify for those randomized controlled trials, depending upon the design. So, and as we know, the trials can answer almost every question for a simpler disease like rheumatoid arthritis. But lupus has so many faces, and we have to look at so many fronts for the lupus that trials probably cannot answer all the questions when a huge real-world population of the patient is not qualifying for them as well. So, and the treatment patterns can diverge from the trial population immensely, keeping in with the heterogeneity of the disease. So a prospective standardized registry data collection can be the foundation for future collaborative research and improvement of patient outcomes. So I will describe the cohort and we'll try to map out the treatment patterns at the baseline for this cohort. So this is a prospective single center observational study at the Fauci Foundation Hospital, Rawalpindi. And we included the patients, adult patients who are more than 18 years of age and who have been diagnosed SLE by a rheumatologist and who have been receiving treatment for at least 3 months. And we had started enrollment since May 2025, and I'd present the data from May 2025 to May 2026. And we have to keep it integrated into the routine clinical practice, we have not defined a strict follow-up rule. We have kept it a bit flexible from between 3 to 6 months. Until now, we're proud that we have enrolled 150 patients, and today I'll be presenting the data of 135 patients. Okay. We collect the demographic history, including the patient profile, including the disease-related questions like disease duration, diagnosis, and the delay between the diagnosis and the symptom duration. We follow the patient's history, personal history, and family history of other autoimmune disorders as well. We map the disease activity by using validated tools like SLEDAI. And when the labs are not available, we use the modified clinical SLEDAI instead of the complete SLEDAI. And then we also have incorporated BILAG along with the physician and patient global assessment for the disease activity. Then we follow the serology levels, which have been done over the period. If they are not available, we do it again for the purpose of this study. We document the damage at the baseline in the form of SLIC ACR damage index, and we do it at the baseline and then follow yearly. Treatment is documented in terms of the steroids, their current dosages, and their cumulative dosage, along with antimalarials and other immunosuppressants and biologics. Sorry, I've gone way forward. Okay, then to include the patient's perspective, in addition to all the objective and subjective criteria, we have included few patient-reported outcomes as well in the form of SF36 mainly. And then we have mapped out flares and hospitalizations from one follow-up to other follow-up. Okay, so coming on to the results. Our population was mainly female, and 97% of the patients were female. coinciding with the general epidemiology of the lupus. And most of the patients were in early 30s at the time of enrollment. And the age at diagnosis of SLE was around late 20s and early 30s. And mean duration of disease at the time of enrollment was 4.6 years. So when we looked at the profile of organ involvement at the baseline, this is actually the organ involvement patient ever had. Okay, as we can see, the maximum involvement was lying in the constitutional form of fever, lymphadenopathy, and weight loss. And the second most common organ which was involved was the mucocutaneous system. And surprisingly enough, cardiovascular system was the third largest, but that doesn't include the features which are included in classification criteria. So it includes pericarditis, includes the past MIs, includes the pulmonary hypertension as well. Probably that's why it is higher. And we have noted the renal involvement in the form of lupus nephritis in 30% of the cases. Okay. Regarding serological profile, our patients showed ANA positivity in 72% of the cases, and anti-dsDNA was positive in 48% of the cases. Anti-Smith was positive in 1/4 of the patients, along with APLA, which was also positive in around 30% of the cases. Rest of the antibodies were present in less than 5% of the patients. But here's a catch that our hospital actually caters the veterans' families. And some of the lab investigations are outsourced, and they are not in our electronic medical record to be followed up. They are with the patient. So they may not be available at the first visit. We ask the patient to bring it on the follow-up. So data is quite missing in this domain. Almost 48% of the data is missing. So probably these are not true representative of the whole data. Okay. Then talking about the baseline disease activity, which was mainly measured by the clinical SLEDAI score, it is reassuring that about 40% of the patients had the SLEDAI score of 0 at the time of enrollment in the study. And about 20% of the patients had fell into the flare category. So it is probably not a quite bad statistic, but remember this is one point data. Okay, and mean SLEDAI score at the time of enrollment was 8.9. Okay, regarding the biggest fear of a rheumatologist in a lupus patient is after the disease activity is the steroid dosage and duration. So we mapped the steroid dosage. 96% of our patients were still receiving steroids at the time of enrollment, and the average dosage of the steroid was 6.57 milligrams per day in the form of oral prednisolone equivalent. And surprisingly enough, when we mapped that steroid into a line graph, we saw that patients with remission had a slightly higher daily average dose of steroid as compared to low and moderate disease activity. So probably the thing which we saw in the last slide that, that a lot of patients are in remission and low disease activity category, but they were probably on steroids. They were maintained on steroids. So, and these steroids did not have any relation with clinical SLEDAI, the dosage actually. Although it's a bit higher in the remission group, but statistically it was not significantly different among different categories. Okay, regarding the steroid sparing and immunomodulatory immunosuppressive therapies, 100% of our patients were using hydroxychloroquine at the time of enrollment. And the second most common drug which patients were using was mycophenolate, which was used in 44% of the patients. By the way, this is not the current medications which patient was receiving. This is the data of the medications which the patient has ever received during his or her treatment tenure. And the agents are not mutually exclusive. Patient can receive 2 or 3 therapies consequently. and in combined forms. And regarding disease activity by the BILAG system, the most active system was renal, with highest percentage of grade A and grade B activity, which formed about 20%. And second most active system was the constitutional, and then neuropsychiatric SLE. So these are, as we know from the epidemiological data, are the main burden of the lupus in the form of organ involvement. So we further segregated to see what is the pattern of medication usage in these patients. About 25% of the patients were using steroids and hydroxychloroquine only, whereas 75% of the patients approximately used another immunosuppressant in addition to hydroxychloroquine. And 45% of the patients were using single immunosuppressant in addition to hydroxychloroquine. Well, if we look at the current medications, we can see that about 23% of the patients were using azathioprine, 5.8% of the patients were using, 23% were mycophenolate mofetil, and 9.7% patients used methotrexate, and third highest drug was aza. And cyclophosphamide and rituximab were each used in 3% of the cases. Okay. So we further looked at the mean number of the immunosuppressants the patient was ever exposed, depending upon the organ domain involved. And what we found out was that patients with renal, hematological, musculoskeletal involvement in the form of arthritis had the highest pill burden. Anything above 1.2 is statistically significant. The pulmonary involvement in the form of ILD, in the form of pleuritis, also counted into that. So the renal, hematological, arthritis, NPSLE, and pulmonary increased the pill burden of the patient. So what we think are the strengths and weaknesses of our data. Okay, I probably am missing one or two slides. They're probably hidden, but what lessons we have learned from this data and how do we compare to the international cohorts? Well, as we have seen, we're probably faring quite well in terms of the hydroxychloroquine usage and the disease activity control. But we need to devise the strategies to minimize the steroid exposure of the patients. We're still lagging behind that. But let's not be deterred by the deficiencies, and let's not be elated by the positive results, because this is only a point data at the time of enrollment, whereas the international cohorts, which tell us that hydroxychloroquine is used in 60 to 80% of the cases, and the large cohorts say that within 3 to 5 years interval, most of the patients who are using steroids fall in 60 to 80% of the cohort. So that is quite high, but that is a longitudinal follow-up and long-term data. What I am presenting is the single point data. So probably there will be changes in these parameters as we follow these patients in the long term. But what are cumulatively strengths of our cohort? That it is prospective design, and we have structured predefined parameters and definitions for the data collection elements, which in resource limited setting is very valuable, where we cannot conduct the clinical trials. And secondly, we use the validated instruments like SF36 for patient-reported outcomes for disease activity and the damage index. By the way, I've not presented the SDI SLIC damage index data, because our data is gradually being digitalized, and we have limited staff. So we digitalize it gradually in the phases. And we have the real-world population reflecting the routine rheumatology practice. That is a big strength of any observational cohort. But we are limited that it is a single center, it is yet a short follow-up, and the sample size is small, so that we were not able to do any subgroup analysis at the time. And there was missing data, like 135 patients, and 30 to 35 patients were still missing from the data, and serology data was missing due to the administrative issues. So what we want to do in future is that we want to expand the enrollment further and take it to 5 to 10 years minimum. And then we would like to have the multi-center collaboration to make it bigger so that our data comes strong from the Pakistan. And we would like to extend the follow-up as well. And when our data is robust and large enough, we'll go for the targeted subgroup studies as well. And since it's not inception cohort, we're planning to do a nested inception cohort from this population as well. So these upper two pictures are showing our team at Fuji Foundation Hospital. And in the left panel, we're celebrating after Lupus Awareness Day celebrations. And the below is showing my research assistant who is collecting data from actual patient. So that was all. And I would like to take this opportunity because Dr. Javed has talked about the genetics, that there is no genetic data from Pakistan. We are planning and we're working on a study on the interferon gene signature in SLE in Pakistan, which would be, inshallah, starting soon. All the workup is done. So this would be a great thing attached with this lupus cohort as well. Thank you. That's all for